morning, everyone. I'll be presenting the Eye of the Storm, a rare diagnosis of ocular tuberculosis. This isn't working. Excuse me. It's not working. Tuberculosis is a serious infectious disease that affects about 1/3 of the world population. Ocular tuberculosis is a rare but known complication of TB. It is re-emerging as a major challenge all over the world. This disease can involve any tissue of the eye and the orbit. Ocular involvement can occur through either direct entry or as an immunological reaction to the organism, which can enter the eye from both epithelial and the hematogenous route, the latter being the most common one. The occurrence is more common in immune-compromised individuals. The commonest manifestation is in the uveal tract, which presents as posterior uveitis. Tuberculous uveitis represents a minority of uveitis cases with varying prevalence ranging from 2 to 4% to 12 to 25% in different areas of the world. Despite significant research over the past decades, the diagnosis of ocular TB is difficult to both ophthalmologists and physicians due to lack of gold standard criteria to diagnose ocular TB, as clinical signs and symptoms mimic other conditions as well. A definitive diagnosis of tuberculous uveitis is confirmed by specific investigations like acid fast smears, culture of mycobacteria, or the PCR-based assays of ocular fluids, that is the vitreous and the aqueous humor. However, the sensitivity and specificity of these tests is not fairly high, making definitive diagnosis difficult. I am presenting a case of 40-year-old immunocompetent male who was diagnosed as ocular tuberculosis. So this 40-year-old male patient walked into the IOPD. He was normotensive non-diabetic euthyroid with chief complaints of diminution of vision in both eyes for 1 month. The diminution of vision was insidious in onset, gradual, progressive, and painless. There was no history of flashes of light associated or any floaters or seeing any wavy objects. The patient also had a history of history of fever for 2 weeks duration. The fever was high grade, sudden in onset, continuous, associated with chills and rigors, and it was not relieved with medication. The patient, in the past, he has had a history of sudden diminution of vision 4 months back when he was diagnosed as papillitis in left eye and was managed conservatively with systemic steroids elsewhere. There was no history of any ocular surgery or trauma in the past. Coming to the examination, the visual acuity in the right eye was 6/9, in the left eye was 6/60. Rest of the anterior segment examination was normal, except for the fundus in the left eye, in which the media was clear, but there were multiple ill-defined chorioretinal tubercles present along inferotemporal quadrant and also around the macula. So a battery of tests were ordered to diagnose the case. Lab parameters showed TLC of 18,000 per mm³ with ESR of 46 mm. His purified protein derivative skin testing was positive with an induration of 18 mm, and that's when we thought of going for quantiferon gold test to confirm the diagnosis if it was tuberculosis. Also, at the same time, radiological assessment was done, which revealed posterior scleritis also in the left eye. After these clinical tests and investigations, a diagnosis of primary ocular tuberculosis was made. The patient was started on high-dose oral steroids after consultation with the chest physician, and along with that, he was also started on anti-tubercular drugs with pyrazinamide, rifampicin, isoniazid, and ethambutol for 2 months as intensive phase, and followed by 4 months of isoniazid and rifampicin. And at 3 months follow-up, the patient showed significant improvement in left eye with a vision of 6/18 with well-defined chorioretinal patches with pigmentation along inferotemporal quadrant and macula. However, the right eye showed no improvement. It was initially 6/9 and later on also it was 6/9. I'm sorry for the bad pictures. This is the only quality I could manage. So this is 3 months post-treatment. This shows healing of the choroidal tubercles, and the pattern has coalesced to form the chorioretinal atrophy. Tuberculosis is a serious infectious disease primarily affecting the lungs. Ocular TB is a vision-threatening variant of TB. Ocular manifestations can vary from lid and adnexa, orbital cellulitis, dacryoadenitis, periocular lymphadenopathy to flectenules, iridocyclitis in the anterior segment. Posterior segment can be involved in the form of vitritis, pars planitis, chorioretinitis, choroiditis, and optic neuritis. Sometimes ocular TB can be the only manifestation of serious underlying systemic active tuberculosis. In certain cases, ocular TB helps physicians to make appropriate early diagnosis with the help of an ophthalmologist and to decide further treatment. Ocular TB is more difficult to diagnose than pulmonary disease. It often needs more sophisticated lab techniques like PCR and gold TB quantiferon tests. Concluding it, tuberculosis can present with variable clinical manifestations. Ocular TB is one of the varied manifestations of systemic TB. This case highlights the fact that a seemingly innocuous eye involvement could be associated with significant systemic tuberculosis and thus requires thorough investigation and timely prompt treatment. Early diagnosis and timely intervention helps in preventing the occurrence of vision-threatening complications in the case. These are the references that I have used.
Thank you, very nice presentation.
Thank you, sir.
So you mentioned that the MRI showed posterior scleritis.
Yes, ma'am.
What were the findings on MRI? How did they diagnose posterior scleritis?
Ma'am, there was enhancement. First of all, they did a USG on which there was a T sign.
No, you did the USG?
No, ma'am. We got it done from the radiology.
Okay, you didn't mention that. So this patient had posterior scleritis or choroidal tuberculoma?
Ma'am, both of them.
Okay.
Ma'am, the patient had the fundus picture that I showed. I could not take the pre-op picture. There were choroidal tubercles that made me think of tuberculosis, and his Montrose was also positive. And at the same time, the patient was complaining of sudden diminution of vision in the left eye. That's why we went for MRI.
Okay.
Did you check for any immunocompromised status of the patient?
Yes, sir. We underwent all this. The
In all
patient
patients?
underwent all the serology, and it was negative.
Negative.
Negative, sir.
Also, when did you see the patients? Because the ATT treatment that was given to the patient was not according to the new guidelines. Was this a very old presentation? Because now ethambutol is
Ma'am, the ATT was put by the chest physician.
Okay.
It was recommended by them.
So according to the present guidelines, now ethambutol is continued beyond 2 weeks. This patient was given this. These were the older guidelines.
Ma'am,
I was
I'll
wondering
see
if when you saw the patient.
to-
So mainly it was a clinical diagnosis.
Yes, sir. It was a clinical diagnosis.
Do you think the recovery was because of anti-tubercle treatment, or it could have been alone with steroids?
Sir,
You gave combination of
So because
steroid.
initially when the patient came, there were active tubercles.
Yeah.
So the patient
Is
should
there
have
any
been
amount of vitritis associated
So
with?
there was no vitritis.
No
The media was
vitritis.
clear.
It was in the choroid and retina only.
It was chorioretinitis.
So what was unusual? Could you just sum up like what is the unusual thing about this case? We see
Ma'am, the,
choroidal. What was
The unusual thing was that ocular tuberculosis would have been missed if the patient was not referred to us by the chest physician, because he had this complaint 1 month back, but then he did not seek any treatment. For fever, he went to the chest physician, and then he told the chest physician that I have ocular problem also.
That's okay. You said a rare diagnosis of ocular tuberculosis. What was the rare presentation in this case? I'd
Ma'am,
like to know.
This is
Apart-
usual presentation.
This is the usual
in
choroidal
which we doubt
tuberculosis. Yeah, you've
tubercular
written a rare.
choroiditis.
So if you
But,
could.
I saw it for the first
No,
time.
you would
so it
have
was
a,
rare.
yeah, that's okay.
At-
So
as a
in your
clinical
mind, what do you
diagnosis,
think was the rare presentation? The tubercles or anything else?
Ma'am, the combination of posterior scleritis along with choroidal tubercles, along with PPD being positive, so that combination for me was
Oh, good. And quantiferon gold was done for these patients?
Ma'am,
Which,
that is, we have a different chest hospital associated with us. That is.
and that turned out to be positive?
That was positive.
Again, in this patients, you could have tried to, in conjunction with the chest physician, asked him to do an endobronchial biopsy, which could have then, given you a better diagnosis.
That was not done. ma'am.
For PCR test, you took fluid from the anterior chamber or from the vitreous tap?
So PCR in this patient was not done, sir.
Not done.
Not done. It wasn't done.
You are very sure about the diagnosis.
So we were sure based on the clinical and the investigations, based on the clinical diagnosis and the investigations. And the patient responded to the treatment also after 3 months, and he's better.
Okay.
He has regained his vision also. He's 6'18". When he came to us, he was 6/60. Now he's 6/18.
So I'm sure you went into literature. How many percentage of patients with pulmonary tuberculosis active would show choroidal tubercles?
Ma'am, I did read, but I cannot quote the
Well,
exact
how
percentage,
then
I don't
did you
want to
know
be
that
wrong.
this was a rare case? You would have gone and read up, right? That
Ma'am,
how
because
many patients
this was
would
one
have.
extra pulmonary case where the patient had ocular tuberculosis.
Okay.
That percentage is 12 to 25% around the world.
Okay.
Yes, ma'am.
We are asking this question because in our time, when we used to diagnose these cases, tuberculosis used to be the first diagnosis. You have to exclude tuberculosis, and ATT was a must in all cases of choroiditis initially.
ATT
But
was
later on, as the investigations further, they grew up, and the people realized that it is not tuberculosis unless proved otherwise. So gradually, ATT was. Am I right? In our time.
So even now, even now for
How
us,
many people give?
even now, choroidal
Many people
tubercle
give
and,
choroid, yeah.
it's
Even
fairly common actually.
even in disseminated disseminated choroiditis is an indication for ATT or recurrence. If there is recurrence, so empirically you can give ATT, but it was all empirical, not definitive. So definite tubercular granuloma to diagnose is very difficult, and biopsy is all disastrous. Thank you very much.
Thank you.